All right, so this video is going to be for part 2 in chapter 6 in your pharmacology book. We left off yesterday on slide 23. We're going to move forward through this. So the next couple slides talk about injectable anesthetics. So it gives you the different options of what those injectable anesthetics are. So general anesthetics also, they're typically short-acting barbiturates and benzodiazepines. So their distribution, they're very lipid soluble, which means they're stored in the fat. They initially distribute to the brain, liver, kidneys, and later on will distribute to the fat and muscle where it's stored. Body distribution lowers the concentration, and then again, most of these, when we're talking about general anesthetics, are given via IV drip. So it goes through the different types of injectable anesthetics. So I'm not going to go into full detail on those because the chapters really do, and I'm trying to force you to read those chapters. Fentanyl, I do want to touch on a bit. So fentanyl is available legally as injectable only or patches. They used to have a like lollipop type thing for fentanyl for our hospice patients, but those are highly restricted now. The fentanyl that you're seeing on the street is not pharmaceutical grade fentanyl. It's fentanyl that's being manufactured illegally, and that's what's causing so much of the opiate overdoses right now, because fentanyl is actually 100 times more potent than morphine. So we go on through things like ketamine, propofol. Propofol you heard a lot, depending on your age, how old you are. Around 2009 when Michael Jackson died, he actually died from propofol use because propofol is only an injectable. It looks like milk. It comes in a glass container and it's white, looks like milk. But they only use this to keep patients sedated, and his physician was using it to allow him to sleep. And all of our patients in the hospital who receive propofol are intubated. And the reason for that is because it depresses the respiratory system. Moving through, so others that list the benzodiazepines. Remember that most benzos are a C4 or a class 4. In the controlled substance categories. So antagonists to reverse overdoses. So there's two that are commonly used or typically only used, and these are stocked very heavily in ERs. They're stocked very heavily in the operating rooms, in both pre-op, post-op, and in the actual operating rooms. Because these are used in the event that the patient gets too much of any of the benzos used or the opiates used during surgery and used for anesthesia. So flumazenil is used for complete or partial reversal of the sedative effects of benzodiazepines that are used in general anesthesia. And again, it's also used to reverse the effects if a patient was to be brought in through the ER. Let's say they had too much Xanax. Okay, it's a benzodiazepine. They would try to reverse that overdose with flumazenil. Naloxone, which is Narcan, another name for Narcan. Naloxone is the generic, Narcan is the brand name. It is an opiate antagonist, and that is what we use for opiate overdoses. In the next couple weeks, you're going to be doing a lab on the opiate crisis in Arizona, and actually the laws now in Arizona have changed and allow the dispensing of Narcan from a pharmacy without a prescription. So we'll talk a little bit more of that later on, but it's because that it's used to reverse all opiates. So heroin overdoses, oxycodone, oxycontin, fentanyl, morphine, anything that is an opiate or opioid classification, naloxone is used to reverse those effects. So neuromuscular blocking agents. They're used therapeutically to paralyze the skeletal muscles during surgery. If you think about it, we have some natural movements that happen, and you don't want someone in the middle of surgery flailing an arm or a leg while a surgeon is trying to do heart surgery. So these contribute totally paralyze the skeletal muscle system, which also requires us to be intubated, because part of that is our lungs. Once all of that is paralyzed, we're not able to breathe on our own. They use it in adjunct to general anesthesia, and it does require an endotracheal intubation. So safety concerns. Neuromuscular blocking agents are one of the most dangerous forms of medications that we have, that not only pharmacy technicians deal with, but we dispense, that we give our patients, because it results in immediate skeletal muscle paralysis, immediate. And that's just not being injected. So I had a situation where I didn't think about it. I was working in the hospital. I was filling anesthesia trays, and I dropped a bottle of Sux, that we call it. It's succinylcholine, and that is a neuromuscular blocking agent. And instead of calling housekeeping, I felt really guilty about calling housekeeping, so I wanted to clean it up myself. And I went to grab some cleaning supplies, and as I was passing back through, the pharmacist is like, "Oh, what are you doing?" And I'm like, "Oh, I dropped a vial of Sux." And he kind of turned around, and then once he realized what I said, he was screaming, "No, don't touch it, don't move." Because had I used my hands to clean it, I didn't even have gloves, it would have paralyzed me, and I would have been in some serious trouble very quickly. So these are things that you need to think about. These drugs should be distinctly flagged during storage. Okay, most of these neuromuscular blocking agents are going to be stored in the refrigerator, and it is also imperative that they are not stored next to any sound-alike, look-alike medications. It goes through the list of what those are on slide 25 and 26, that you can review those. So local anesthetics, they produce a transient and reversible loss of pain. So not only to pain, but also temperature, touch sensation, skeletal muscle tone in a defined area of the body. There's no effect on mental function. So again, where it's injected locally, that's where it stays. Epinephrine is commonly used in conjunction with the local anesthetic to keep the local anesthetic at the site, and prevent it from being absorbed into the bloodstream and kind of spreading through. Esters are short-acting, and they are metabolized by the pseudocholinesterase in the plasma. Amides are longer acting, and they are metabolized by the liver. So it's different forms of these medications are actually metabolized in different parts of the body. So part of your assignment is going to ask you to list the different esters for local anesthetics, and those are listed on slide 29 along with the amides. You can also find it on page 204, I believe, in your pharmacology book. So lidocaine is probably one of the most common anesthetics that they use. Not only do they have it in an injectable form that they use for, if you're lidocaine for your mouth, for dental work, lidocaine in an injection if you need stitches or sutures, but also they have now some lidocaine patches that they're trying to help patients get on to avoid the opioid use. And so these patches, they're available by prescription only, but they do contain lidocaine, and they're in a patch which they apply to whatever part of the body they need to, and it provides that localized pain relief for a period of time. Those patches are worn for 24 hours. So the patient will start it in the morning, wear it for a full day, change it, and put the next patch on in the morning. So pain management. Pain is a protective signal to us that is warning of damage or the presence of disease. And pain is also a natural part of healing. We don't like to hear that, but when we have surgery, that pain that we have during recovery, that's actually normal. That's a normal part of healing. Acute pain is associated with trauma or surgery, which means it has a beginning and an end. So when we have any sort of trauma, or if we have any major injuries, you roll and break your ankle, or you have any type of surgery, that's acute pain. It began when the injury or the surgery took place, but as that will heal, the pain will subside. Chronic non-malignant pain, the cause may or may not be diagnosed, and typically it's categorized by pain that's lasting longer than 3 months, and typically could respond poorly to treatment. And this type of pain chronic non-malignant, is also classified of not ceasing or getting better when an illness or injury is healed. Chronic malignant pain is associated with malignant disease, typically cancers, or any type of progressive disease that causes pain, which means that the pain increases in severity as the disease progresses. So there's 4 different types or sources of pain: somatic, visceral, neuropathic, and sympathetically mediated. And they have, different types of adjectives that describe what people feel when they have that type of pain, and then it also has the associated treatment there on slide 32. So narcotics are used as a pain modulating chemical that is generally an opiate. The effects are analgesia, which means pain relieving. You get sedation, but you also get euphoria. So that's part of where the addiction process can take place when people are using lots of opiates over time. Tolerance, every patient that is on pain medication will develop a tolerance. It just depends on how long that they're using it. Now with our opiate crisis, the physicians and in guidance with not just the federal government, but also the CDC and other entities, are requiring or recommending the shortest term of narcotic use as possible to get the patient through whatever painful ailment or disease or whatever that they're suffering from. So what happens is that for every single person, the longer you use an opiate, your body naturally becomes addicted to that. And so what happens is, when you are using an opiate and you are supposed to be only using it for the 7 days, your body becomes accustomed to that in 7 days. If you continue using that, you're going to need more or an increased dose of the opiate to feel the pain relieving effects. And that is because your body is becoming addicted to that dose. Eventually, you're going to need higher and higher amounts of dosages. That's what happens to addicts. Most addicts move on from opiates like oxycodone, morphine, fentanyl, to heroin because it's cheaper, because as they go on, they need a larger amount to fill the high. So part of that includes the impairment of judgment and psychomotor function. So that's why they tell you don't operate heavy machinery, don't drive a car until you know how you are affected by this. Constipation is huge. People that are on opiates, there should always be a secondary prescription or order for a stimulant laxative, because long-term use and higher doses of opiates cause constipation, severe constipation. Treatment of a narcotic overdose is an assisted ventilation, so we can intubate them to breathe for them, and then giving them a narcotic antagonist, which would be the Narcan. There's a pyramid here that actually gives you an idea of what types of drugs are used to what type of pain: mild or intermittent, mild pain, mild to moderate, and then severe. Schedule 2, so we know that the DEA classifies controlled substance drugs into 5 categories. C1 would be things like heroin, marijuana, LSD, illegal street methamphetamine, speed, I don't know what else they call them. Those are the highest addiction or highest addictive potential, but they also do not have any medicinal use. Yes, I said marijuana, because according to the federal government, marijuana does not have medicinal use. It has not been approved or considered an illegal or a legal substance from a federal standpoint. All of that determination has been made by the states individually. So the original hard copy of the prescription with the physician's DEA number must be presented at the time of filling for C2 medications. If we do not have enough stock of the drug for the patients, we must fill that partial fill. We must fulfill that within 72 hours. Specific computer requirements for electronic prescriptions. So what that means is the physician's office must have the same type of controlled substance software or ordering software that the pharmacy does in order to send a C2 prescription electronically. If they do not, the patient must bring it in as a handwritten copy. C2s can be filled within a year of the date written, but they have 0 refills. They do not get any refills. We order C2s, not we as technicians, but pharmacists order C2s on a DEA 222 form, and then all destructions of the drug must be witnessed on a DEA form 106. Most state regulations are more strict when it comes to controlled substances. So one perfect example is that in the state of Arizona, we do not allow dispensing of any C5 oral syrups that contain codeine, and in some states they allow it without a prescription, but in the state of Arizona we require a prescription. So since Arizona law is more strict, we will always follow the more strict law. Addiction and dependence. So dependence is a physical and emotional reliance on a drug. Withdrawal is when a drug is discontinued or the dose is reduced. Addiction is a disorder leading to continued use of the drug despite the harm. Symptoms can include preoccupation with drugs, refusal to taper off the drug, a strong preference for a specific opioid. We see that a lot. I used to work in behavioral health, and they get pretty manipulative. You can also see an increase in attempted forged prescriptions, frequent prescription loss, where they tell you that they lost their bottle, they need a new one, changes to the prescription, any unsanctioned dose escalation, and the reports of patients of short medication supply may indicate an addiction. So let's say that we give them a 30-day supply, and that's good for a couple months, and then we start noticing they're trying to refill it a week early, and then 2 weeks early, and then 3 weeks early. That means they're running out too fast. They're not taking it as prescribed. So there's different medications to treat addiction. They do have methadone. There's a couple of methadone clinics. There are a couple of Suboxone clinics here in town, and that's on slide 37. You can read through those and see how they work. Narcotic analgesics, again for pain management. So an analgesic medication that is derived from an opioid. Dose requirements, it varies with the pain severity, the response to the pain. It also has to, the dose depends on the patient's age, their weight, and what the disease is or what other additional diseases they have. Morphine is the standard to which all narcotics are compared or measured to. Side effects obviously are pretty much the same. You can get a lot of nausea and vomiting, dry mouth, constipation is huge, and then it does decrease your respiratory. Goes through the list of narcotic analgesics. So combination drugs for managing pain. So combination drugs are set up to work both centrally and peripherally. The purpose is to increase pain relief through drug synergy, which is the drugs working together in different areas of the body. Limit the intake, and also the purpose is to limit the intake of addicted substances. So if we can use an oxycodone with Tylenol instead of just a pure oxycodone, we can use a smaller dose of the oxycodone and a higher dose of the Tylenol. Dose limits, so due to the serious risk of either ibuprofen, Tylenol, or aspirin overdoses and their daily limits of how much you can have, it's very dangerous for people to overtake these combination drugs. Filling prescription with combination drugs. So the strengths for both components must agree with the prescription. So, if you see that it's written as oxycodone 5 milligram and, Tylenol 150, that should be a red flag. The Tylenol or acetaminophen in all combination narcotic drugs, Vicodin, Percocets, is limited to 325 milligrams for the Tylenol. It gives you a list of what those combination drugs are. So migraine headaches, a lot of people suffer from migraines. They're described as a severe throbbing headache that's accompanied by symptoms such as nausea and vomiting, sensitivity to light. The components of the migraine, typically there's kind of a they can feel it coming, they can see it, sense it coming, they get almost an aura, and then they get the headache itself. Finally, they get some relief. The aura is the visual or sensory disturbances, such as seeing flashing lights, shimmering heat waves, bright lights, dark halos, or even a transient loss of vision. Migraines usually last 6 hours, but sometimes they can last 1 or 2 days. So the pathophysiology of migraines is that's the dilation of cerebral surface vessels, which increased levels are followed by a decreased level of serotonin. Risk factors include diet, stress, certain medications, hormone fluctuation, depression, even atmospheric pressure changes for some people. Non-drug therapy would be identifying and eliminating the trigger factors. So going to a quiet environment, making sure they're getting enough sleep, and then as they feel something coming on, maybe going and laying down in a dark room. So there's different types of medications. So we do have prophylactic therapies for patients that are frequent migraine sufferers. So they would take these daily to prevent them from happening. And then we have the abortive therapy, which is the migraines already happened. And so triptans is a class, and you notice by the rizatriptan, sumatriptan, right? The suffix in the name, triptan, that's your indication that it is an anti-migraine, okay? And they all work similar. Ergot derivatives, they work by causing vasoconstriction, and then there's a couple, Migranal is one common one. Side effects are nausea and vomiting, and then there are some cautions and considerations when prescribing these for patients, especially that are at risk for cardiovascular events. Antiemetics, so anti-nausea or anti-vomiting. They block the neurotransmitters which cause nausea and vomiting. Some examples include Thorazine, Reglan, Phenergan. The side effects are drowsiness with most of these, and there is cautions, especially in patients with liver disease and any type of congestive heart failure. Opioid analgesic, Stadol, other migraine agents, Tramadol. Tramadol actually used to be available just with a prescription. It was not a controlled substance. That changed, I believe, in 2014 or 2015, and it was required that it was now AC4. Caffeine. Caffeine is a huge central nervous system stimulant. It is used in combinations with other analgesics to treat headaches. So one of those examples is Fioricet and Fiorinol. These contain butalbital, which is a barbiturate, and then Fioricet has Tylenol in it and caffeine. Fiorinol has the butalbital, aspirin, and caffeine. They also use caffeine to treat fatigue and drowsiness. Should not be used more than every 3 to 4 hours, but most of us, not so much the case, right? Because I drink a lot of tea. Side effects can include rapid heartbeat, palpitations, insomnia, restlessness, nausea and vomiting, stomach pain. So capsaicin, Feverview, And even cannabis, right? So they actually have cannabis listed here as an alternative or a complementary therapy. But remember, it depends on the state. Some states allow medicinal use, some states allow recreational use. But according to the federal government, it's still considered an illegal substance. So capsaicin is a topical treatment. It's a natural occurring substance that we use topically. You can find it in most over-the-counter pain relieving creams. Feverview, can be used. It's a supplement that people use orally to help prevent migraine pain. They also use it to treat menstrual cramps and even pain associated with arthritis. And then they use the marijuana extracts, both synthetic and natural extracts, for chronic neuropathic pain. We see a lot of it used for cancer patients and cancer pain and stuff like that. And we have made it through chapter 6. Congratulations. So for the rest of this, you will go through this video, you will review the rest of the slides in the PowerPoint and finish reading your chapter 6 chapter in your Pharmacology for Technicians book. And then you will complete the daily assignments. There's 2 daily assignments and a discussion board. So there's 3 things to complete for Wednesday's assignment.